My lady, may I call Professor Russell Viner?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but
and nothing but the truth.
Thank you.
Thank you for coming to help us, Professor Viner.
Professor, you have in front of you a witness statement which you helpfully provided for the inquiry. It's INQ 000588157. Is that right?
Correct.
Professor Viner, you're an academic pediatrician and a fellow of the Academy of Medical Sciences, a fellow of the Royal College of Pediatrics and Child Health, and a fellow of the Royal Australasian College of Physicians. Is that correct?
Correct.
Since 2012, you have been employed as a professor by UCL Great Ormond Street Institute of Child Health, as a professor of adolescent health, having first practiced there in 1997. Is that correct? In your witness statement, you tell us that your expertise as a clinical epidemiologist lies in child and adolescent public health and policy, particularly relating to health services, mental health, and obesity. You are not an expert in infectious disease. Is that correct?
Correct.
Professor Viner, many of us, upon hearing the word epidemiology, I think have in mind an expert in infectious disease. Can you just explain to us briefly what a clinical epidemiologist is?
Of course. Epidemiology is the study of patterns of disease or illness. Infectious epidemiology, of course, is one big part of it, but there's also non-infectious epidemiology, for example, non-communicable diseases, and in particular also the study of policy responses to problems.
Okay. So one example of a non-infectious disease which would be could be studied by a clinical epidemiologist would be obesity, for example.
Yes, or mental health, or yeah.
I see. I'm going to move on now to your roles and responsibilities during the pandemic. You were president of the Royal College of Pediatric and Child Health between 2018 and 2021, is that right?
Correct.
But you're not giving evidence today in that capacity.
No.
We, in fact, my lady, will recall we heard from Professor Steve Turner from the RCPCH early on in this module. You continued throughout the specified period in your role as a professor of adolescent health at UCL.
Correct.
You were a scientific advisor to SAGE from about the 14th of March, is that right, 2020?
Yes.
You tell us in your witness statement that you were first invited to SAGE by the Chief Medical Officer, Professor Sir Chris Whitty, because of your expertise, and you went on to attend a total of 12 SAGE meetings. And you say that you attended SAGE when it related to children or schools, and that you restricted yourself to those subjects. Is that right?
That's right.
From April 2020, you were a scientific advisor to the Children's Task and Finish group, and you tell us that you were invited to become a member of this group following your attendance at SAGE, and that you attended 14 meetings. Is that right?
Correct.
Okay. And finally, you were a scientific advisor to the Scientific Pandemic Insights Group on Behavior, SPI-B, in the main attending on occasions where meetings related to children and young people.
That's right.
Okay. In your witness statement, you state that you used your expertise in evidence synthesis and systematic review to carefully gather all emerging evidence on the severity of disease, susceptibility, and transmission of infection in children and young people. And for this, you worked with experts in infectious disease in childhood, and you undertook a number of systematic reviews of emerging international data. Some of that work was prompted by your discussions in SAGE subgroups, and some you undertook within your personal capacity, and that you fed your findings back to the Chief Medical Officer.
That's correct.
Okay. And just before we go on to look at some of these systematic reviews, your present role is the Chief Scientific Advisor for the Department for Education,
That's right.
and that role began in January of 2023, so outside the specified period.
Correct.
And your evidence to the inquiries provided in your personal capacity, not on behalf of the DFE either. Okay. And can I understand that you're not here today to represent the views or policies of the Department for Education or any other organization, but you're giving evidence from your own recollections and opinions accumulated from your wider work and experience. Is that right?
That's right.
I'm going to ask you now about the developing evidential picture about the transmissibility of COVID and the susceptibility of children and young people to COVID. If I can begin with the early period from mid-February. In your statement, you note that from that time, and this is before you were involved in SAGE, you noted that schools were being closed in countries such as China and elsewhere because of COVID-19, and you noted a growing discussion of the potential for school closures elsewhere. And you decided to search the literature for evidence on the impact of school management practices on coronavirus, and you provided a rapid systematic review. Is that
That's
correct?
right.
Okay. You shared an early draft of that systematic review in March, roughly between the 15th or 17th of March, with Professor Sir Chris Whitty. That was right on the cusp of the decision to close schools. And can I just ask you, that early piece of research, what did it show?
So it's important to emphasize the uncertainty and lack of information. If I can give you a slightly longer
Please.
answer. When I was president of the college, we were starting to get concerned about how children fitted into this pandemic, with reports coming from China and then Iran and then Italy. As president of the college, and I'm not trying to mix up roles, but one is one person, even though you have many hats.
Yes.
We would be getting information from pediatricians in those different countries, and particularly in Italy, and starting to think about what might happen if the UK was involved. We worked very closely with colleagues at NHS England and with the other Royal Medical Colleges, and were briefed by the Chief Medical Officer. So there was quite a lot of thinking we were doing at the time within that Royal College. And I was keen to bring some of my broader academic expertise to that, and this expertise in evidence synthesis. Because schools were closing in a number of other countries, these discussions were happening, both in the press, but also in more clinical and academic circles about school closures. But I was very keen to understand what the evidence was. So I undertook a systematic review, and a systematic review is essentially not undertaking new research, but in an incredibly careful and systematic way, identifying all the research that is either published or about to be published on a topic, and carefully and objectively synthesizing that. And it is a skill that we had used in my previous academic life.
And can I take from that you are also gauging the quality of the studies that are out there?
Yes.
And choosing those of
So
a
an
higher
important
quality?
part of it is looking at quality. So as data started to come in, we had formed networks whereby we collaborate amongst different academics, and I would be informed of a paper that was about to be published or had just been published somewhere in the world about the pandemic, and through informal and formal networks. And I started to, in a sense, collect these. And then my mind turned to actually doing a formal systematic review once there was enough data. It's very different to just having a collection of papers and here's my view, but actually binding yourself to a set of rules that you set up beforehand about how one does the review, and then being very careful in the reporting of it and judging the quality as part of that. So to answer your very specific question, I looked for evidence from the Far East, from China and Taiwan and other countries, from any other countries. I looked for evidence from SARS-CoV-1 or the SARS pandemic. I looked at evidence from other coronavirus epidemics to see whether there was any data on schools and children in those, and looked for any data that was immediately available on SARS-CoV-2, the COVID-19 causing virus. There was very little information on any of those. There was little information that school closures had been useful or important from SARS-CoV-1, though that was less relevant. And in fact, in the absence of evidence, we concluded that we needed to learn from the influenza literature, but think carefully about it. And I think one of the issues is about how much the influenza literature affected people's thinking, which we may come back to.
Yes, I will move on to that in due course.
So what this system, your question, what the systematic review showed was that there was little evidence to support school closures, and the evidence from the influenza literature was that viruses that had the characteristics of SARS-CoV-2 or COVID, actually school closures were likely to be less effective.
I see. I'm going to ask you now about your view of the advice provided to the government about the likely efficacy of school closures. And for that, I'll take you to the SPIMO consensus view of the 17th of March, so right around this time. It's INQ 000253871. Yes, thank you. So if we can, yes, on page 2, paragraph 9, it says, it is almost certain that school closures will not make the epidemic worse, and that they would reduce both the epidemic peak and expected number of cases. Our best assessment is that they would reduce the reproduction number by between 10 and 20%, and we do not know how likely it is that this will change the reproduction number from being above 1 to below 1. From your, judging from the state of knowledge at the time, do you think that this advice given to SAGE was the correct advice?
I believe it's very reasonable advice. I would emphasize the extraordinary uncertainty that we were facing. Children, we knew almost nothing about transmission of the virus from children and between children in schools. And I think the key thing in this statement is that schools would contribute, and there's also other paragraphs in this document, that it's about schools contributing to overall closure rather than schools closures being highly effective in their own right.
Yes.
And I think that's something I absolutely support, but I just wanted to emphasize the uncertainty.
Yes, I see. Well, that can come down now. We've heard evidence, and I think I've understood you correctly, that school closures on their own would not represent a significant measure, but that taken as a part of measures, as a collection, could have an impact. Have I understood that correctly?
Absolutely.
Okay. I'm just going to take you quickly now to the...
And that was the state of knowledge at the time.
Yes, of course, sticking with what was known at the time. I'm going to take you now briefly to the minutes of the SAGE meeting 17. You didn't attend this meeting, I should say. It took place on the 18th of March of 2020. And if, thank you very much. We're just looking at page 3. There's a paragraph here on school closure. So this was the advice given. You weren't involved in this directly, but I'd just like to ask you about your views on it. So it says, SAGE reviewed available evidence and modeling on the potential impact of school closures. The evidence indicates that school closures combined with other measures could help bring the R number below 1, although there is uncertainty. And then there was a discussion about the impact of school closures in terms of alternative childcare arrangements, which could reduce the effect of the closures, and the consideration of keeping schools open for particular groups having an effect on the impact of that measure. SAGE considers that modeling now supports school closures on a national level and that the effect would be greatest if instituted early, and some considerations about clear public messaging. Overall, do you agree with the advice given here about, there is some uncertainty, but about the efficacy of school closures combined with other measures?
Yes. I believe that at the time, the uncertainty was so great, we had no specific knowledge on transmission of the virus to children, from children to adults, between children. We had almost no information on the susceptibility of children to the virus, whether they catch it. And I think the concern about, certainly in my world, within the health system, the real concern was about the collapse of the health system and the overwhelming of adult intensive care units, such as has happened in Italy. There wasn't happening to children's intensive care units, interestingly.
Okay.
That this seemed a reasonable advice, and I think scientifically it was supported. I would have supported it.
Thank you. And just, that can come down now. And just to confirm, you weren't involved, your involvement in SAGE and the Children's Task and Finish Group arose later. You weren't involved or present at the discussions to close schools. Is that right?
I was not. The SAGE meeting I went to, which I believe was slightly earlier, 11th of March,
I think it's the 10th, you say in your
10th
statement.
of March,
Yeah.
yes.
Yeah.
School closures were mentioned obliquely, and that was largely focused on the imperial modelling, which showed school closures produced a small, but they felt important, additive effect.
Thank you. I'm going to move on now to mid-2020, around that time period. In your witness statement, you state that your views about the role of schools in transmission changed for a number of reasons, including because of a further systematic review that you undertook. And if we could just move to that, please. It is INQ 000542939. And this is a systematic review on the susceptibility to SARS-CoV-2 infection among children and adolescents compared with adults. And susceptibility means the ability for children to become infected, is that right?
Correct.
Okay. And what did, if we move to page 2, please. Yes, we can see at the top here. In this systematic review, including 32 studies, children and adolescents younger than 20 years had 44% lower odds of secondary infection compared with adults 20 years and older. The finding was most marked in those younger than 10 to 14 years. Data was insufficient to conclude whether transmission by children is lower than by adults. So can I take it that the systematic review showed that children were less likely to become infected, about 44% less likely, but you couldn't tell whether once infected, they were more or less likely to infect other people? Have I understood that correctly?
That's correct.
Okay, now that can come down now. You also mentioned in your statement the school's infection survey having informed your views. Can you just tell us briefly what the school's infection survey was?
Can I give you a slightly broader answer?
Yes, please.
So once lockdown happened, we continued to get information from other countries, and all countries across Europe and clearly internationally were also in a similar situation. And we started to also receive information, particularly from the Netherlands, and then looking at some of the Nordic countries about what was happening in schools. We also had a lot more information about the severity of this disease in children. And a picture started to emerge where we were getting new data. So there's three key issues. Firstly, susceptibility. Do they catch it? Then severity. If they catch it, how severe is it? And thirdly, do they pass it on? And we had very good data on severity, the middle one, which we started to recognise that actually this was generally a very mild illness in children, that the severity was low. Susceptibility, there was starting to be some emerging evidence that may be lower, but we still had very little on transmission. But given that, and given the low severity of disease, I mean, our intensive care units were pretty empty, there were some deaths. I'm sure you'll ask me more about this, and I can go into that later, but generally the severity was low. We were clearly in a situation where schools were closed to benefit adults largely, as well as benefiting children. But because the severity was generally so low amongst children, it started to change things. And I started to think differently about this virus and really question whether we needed such long lockdowns and really search for the evidence. The Nordic countries started to reopen, and some of the Northern European countries started to reopen schools from either late April or May, having locked down at a similar time as us. And I really started to question, what do we know? How much do we know? And can we make statements that then change things? So that susceptibility paper was part of that, and that was undertaken with colleagues from SAGE and elsewhere. We also started to look at potentially some modelling transmission in a different way, including the data on susceptibility and or severity.
Okay. And as part of that, the school's infection survey, I think you say, also helped you kind of work out
Yes.
how transmission was happening.
So this was once schools were reopened on the 1st of June. It was primary schools and some of the exam years in secondary. And colleagues from Public Health England undertook the schools infection survey, which found almost no infection at all in those open schools, extraordinarily low levels, which you can either take as it's been incredibly successful, the closures and the lockdown, or you could take as evidence that there was actually very little transmission happening in those schools at that time.
Mm-hmm. You mentioned work that you undertook for SAGE, and I think you're talking here about a paper that you had authored on the transmission and symptoms in children, and that was prepared for SAGE on the 15th of October of 2020. It was a paper developed within, I think, the subgroup of the Children's Task and Finish group. Can you just tell us briefly what that paper showed, like what your conclusions were about transmission in children?
So data on transmission remained very complex until right later in the pandemic. Mm-hmm. You're asking me about October now?
Yes, the 15th of October.
So that paper, if I recall, on symptoms, this was quite a lot later in the pandemic, when all schools were reopened in the beginning of September 2020. There were real concerns about, at that stage, trying to differentiate symptoms of COVID from ordinary colds and flus. As most parents will know, most younger children in particular will have a runny nose or a sore throat even up to every 2 to 4 weeks, particularly during winter. And actually, if we operated policies that kept them off school for a runny nose or a sore throat, we may actually have no one in school at all. So there was an importance in trying to distinguish some of the symptoms of COVID.
I see.
From ordinary coughs and colds, particularly from the rhinovirus, which is a virus that sweeps through our children and schools in September, usually September, October. At that stage, we were also trying to understand a bit more about transmission, but our knowledge on transmission remained very, very poor, and we were unable to make significant recommendations about transmission.
Okay. Well, if I can move on then to 2021 onwards, you conducted 2 further systematic reviews in 2021 and 2022 on the impact of school closures on community transmission and on the role of children and young people in schools and transmission. And I think in your statement you say that those reviews strengthened your conclusions that schools made a limited contribution to transmission. Is that a fair summary?
It's a very fair summary. I can enlarge, but I will also answer questions. Yes.
Yes. If I could ask you, in addition to the rapid reviews, you also began working with a modelling team based at the University of Oxford on the reopening of schools. And you produced 3 papers, which were shared with the Chief Medical Officer in June and September of 2020, and then also in February of 2021. I'm just going to take these briefly now, but the first paper was entitled Determining the Optimal Strategy for Reopening Schools, the Impact of Test and Trace Interventions, and the Risk of a Second COVID Epidemic. That paper was in preprint in June 2020. Can you just tell us briefly what that modelling paper showed?
So that modelling paper showed that it was feasible to reopen schools as planned on the 1st of June, that because there was some discussion about whether schools should stay closed for longer, and there were great fears that this would result in a second pandemic wave. So we wanted to model that and found it was feasible to reopen schools and not cause a second pandemic wave if there was a functioning test and trace system in place that involved schools. So we felt this was important in supporting the opening of schools. We didn't predetermine what our modelling found, but it was very important to me that we constantly shared emerging findings before publication with key people. And the key person for everything I did during this time was Chris Whitty, the Chief Medical Officer, whom I knew through my role at the Royal College, whom I then obviously knew through SAGE, and emerging versions of this. So before final versions, I would always routinely share with Chris Whitty and also with Patrick Vallance, the other, the government CSA, Chief Scientific Advisor.
Yes, I think in your statement you set out the dates
Yes.
for the preprints that were shared with the Chief Medical Officer, and sometimes they're quite far in advance of the date of publication
That's
of the
right.
study.
And I often, I believe, informally shared earlier versions with them too, though I don't have the exact dates.
I'm sorry to interrupt and hold whatever thought you've got in your head, Ms. Fodl. I just want to go back a little. I should have asked at the time, forgive me. You said that one of your reviews showed that schools made limited contribution to transmission. I think it was Professor Chris Whitty who talked about the gathering of parents, and other witnesses have, gathering of parents around the school gates and the like. Is that an important factor, or do you think that's an overestimated factor in causing increased transmission?
I don't think I have the science knowledge to answer that question. I have to be absolutely frank. None of the data that I've seen really looked at the role of parents around the school gate. It was something that came up, as you mentioned, quite frequently. But we didn't have any clarity really about transmission until much later in the pandemic. And I assume you'll ask me about that in a minute. But.
Yes. Before I do, you mentioned that the modelling paper that we just discussed was produced around the time of schools being reopened because there was a debate about whether it was appropriate for them to reopen at that stage. Overall, do you believe that the correct approach was taken to the reopening of schools from a scientific perspective?
Yes. From reopening schools on the 1st of June, I would have been very unhappy from a scientific perspective for that to be delayed, particularly given our modelling paper. I was disappointed that it was only primary schools that were fully reopened. There was, our paper on susceptibility and others, I think there was a belief, there was an acceptance that primary school children were less likely to be severely affected, etc., probably play a lower role. That was more broadly accepted, but there was a concern about teenagers, and particularly the behaviour of teenagers in social mixing, that I think drove people to continue to keep secondary school or part of secondary school closed at that time.
Okay. You mentioned in your statement the role of pandemic influenza thinking influencing some of the debate about transmission in children. And can I just ask you, overall, what your view on the evidence as to children and young people as super spreaders, if I can put it that way, is?
So right early in the pandemic, people, modelers and infectious disease people and others relied on their experience of influenza, which is a common epidemic and pandemic condition where children are in many cases super spreaders, or they are actively involved in spreading the disease. And I think the assumptions were that COVID would be the same. And that's the evidence, the evidence emerged quite early on that there was a different picture, particularly for children. But I think that thinking very much influenced people. I would also want to say, there's also there was a general feeling that children were agents of disease, and much of the thinking about school closures and what we did with children was about controlling transmission from children. There was much less thinking about harms to children. There was quite early on a recognition that children were little affected by the harms of the pandemic, but most of the thinking around children was about control and stopping them being agents of infection. And less thinking about harms to children and the rights of children. And I'm sure you will come on to ask me about this.
Yes, I have two specific questions on that first before we come on to discuss the other impacts. Firstly, in relation to the Children's Task and Finish group, I've been asked by a core participant to clarify an issue. Do you agree with Professor Rogers that the group were confined to carrying out research tasks commissioned by SAGE and therefore confined to answering the questions posed to them? Before you answer, the second part of that question is, do you think that the group could have looked at wider issues concerning children had they been tasked to do so? For example, more analysis of the harms done to children by missing school and or the impacts of the lockdown rules on children generally?
I was unaware at the time exactly how the group worked and who commissioned what. In my current role, I clearly have a much stronger understanding of how government works, but it can be difficult to understand if you're not in it. Yeah. I was there as a scientific expert. My understanding was that we were tasked to look at specific issues by government. That the Task and Finish group was a subgroup of SAGE, so it was both tasked by SAGE, but it was also tasked by government departments to look at specific issues. And it was largely confined to that early on. Later on, the group did look very strongly at elements around harms.
Yes, and I suppose your point earlier about perhaps an absence of consideration of these wider impacts, about not just controlling infection for children, but the wider impacts on them of the pandemic and the closure of schools. Do I take it from your evidence that at an early stage, it wouldn't have been open to you on the Children's Task and Finish group to conduct deeper analysis on that issue? You were confined, or the group was confined, to what it had been asked to look into by SAGE or other government departments?
I believe that is correct. And certainly in terms of some of the modelling issues, again, we were interested, I remember some colleagues and I were interested in asking modellers to look at some of the different options around schools, because school closures don't need to be full or zero. They could be partial closures. There were potential options we had seen in the literature for having half the years in the morning and half the years in the afternoon, or alternating weeks, or splitting up the schools, because the key issue there was to try and reduce the number of contacts between students. And there's multiple theoretical ways of doing that. But there were. As I said, exactly who was commissioned and how that was controlled is not something I knew about at the time. But I certainly knew that there were some things that we were suggesting be looked at by the modellers that were not looked at.
You set out in your statement that plans to implement rotated school attendance were not prioritised due to concerns that parents may struggle to get children to school, and that the teaching capacity might be insufficient to run rotas, for example. Was there, and this is a question I've been asked to clarify by a core participant, where there is both an imperative to restrict transmission and also an imperative to try and avoid very lengthy periods in which teachers do not have face-to-face contact with children, might rotated attendance have been a means of achieving both aims, in your view?
Yes. Theoretically. So we were operating from theoretical knowledge. But as I understand it, there were, and I don't know where this came from, potentially the Department for Education, but it was felt that these were not practical.
I see. I'm going to move on now to the impact of COVID-19 lockdowns on children and young people's physical and mental health.
So just before you go and
Yes, of
again,
course.
Apologies. It was felt it wasn't practical, but it was felt it wasn't practical without asking experts like you to consider if it was practical.
Well,
Is that right?
so I'm probably not my lady, I'm not probably an expert on whether things are practical or not, to be honest. Those who operate schools and run schools and commission schools are probably the experts on that. So that I would say they probably had more expertise than I. But we were keen that lots of different options be looked at, rather than full closure or not. It felt very binary.
But as part of your expertise, you could have conducted modeling studies to show whether, let's say, schools operating on a rota, you could have modeled the infection risks from parents bringing their children to school twice in a day, or one imagines there could
The
be-
modelers could. So just to be clear, my expertise is not modelling. I worked with modelers,
Yes.
this particular modeller for Jasmina Panofsky-Griffiths, using interesting and different modelling techniques, interestingly, that weren't used by some of the others, to look at this slightly differently. But I'm not a modeller myself.
No, pardon me, that was my error. But what I was trying to get at is you might not be an expert in what's practicable in schools. So, for example, how much teaching staff, how much they're available. But you, as the scientist, could have provided expertise on whether different arrangements could have been sufficient to bring down transmission.
Yes, I could have worked with modelers and thought about that. And as I think I mentioned before, from the actually influenza literature, but there had been some papers I had discovered in my systematic review that had looked at the potential impacts of these partial attendance, rotating attendance systems. Some of us were keen that they be better looked at.
Yes, and that work was not commissioned.
I don't believe so.
Okay. Then, if I can move on to deal with the physical and mental health impacts of the lockdowns. You authored a paper on deaths in children and young people after COVID infection and on risk factors for pediatric intensive care admission among children hospitalized with COVID and with PIMS. Can you tell us, in summary, what that research showed?
Firstly, there were a small number of deaths of children and young people in this country from COVID-19, that sadly those most at risk were those children and young people who were most at risk from all viral infections, particularly those with significant neurodisability, and especially when that's allied with a respiratory problem. We found that the great majority of children who died and had a positive COVID test actually died. We said that the positive COVID test was incidental. That because COVID was so common, that the death of any child is such an extraordinarily sad event. But when it might occur, when there's a common infection around, some of those deaths, the infection will be incidental. So we worked very hard to try and work out, and found that supposedly of deaths with a positive test, only 40% of them we felt were from COVID rather than children who die with COVID. It's difficult to talk about some of these things. We also found that the risk from COVID to children and young people was higher than seasonal influenza, undoubtedly, but not a huge amount higher. Again, that the children who were at risk were those who we know were at risk from any winter virus, and also that the adult risk factors, which were obesity and other medical conditions, were also seen in children. But we also found that deprivation was a major risk factor.
You might not be able to tell us this, but can you give us any indication of why deprivation would be a major risk factor?
Deprivation was an amplifier of every other risk factor in many senses. So it produces crowding, which increases the likelihood of catching. Deprivation, parents, so families from deprived situations have fewer resources. Parents may have less ability or less education, so absolutely as much care for their children, but they may have lesser resources to be able to put that care into effect. There's the potential for barriers to them accessing healthcare, whether that's from a range of different reasons. And those children themselves may be less well nourished. Their immune system may be less well primed, in a sense. So there's a whole bunch of reasons, right? So it operates through almost everything.
I see. I'm just going to ask you now very briefly about long COVID and other post-viral conditions. You conducted a meta-analysis of studies on long COVID in children and young people, which was published in the autumn of 2021, so at quite an early stage. And as part of that meta-analysis, you called for higher quality studies into the phenomenon with a control group. Moving on now to the present day, I think you've seen the expert report commissioned by this inquiry on children and young people, which is dated August 2025. That report relies on findings of the CLOCK study, and that is, well, you tell me if I'm right about this, a higher quality study with a control group. Do you agree with that?
Yes, absolutely.
And do you agree with the conclusions in the expert report about the prevalence of long COVID in children and young people?
Yes.
It's not your report, so I'm not going to take you to it and ask you whether you agree with different aspects of it. But there's one question which I've been asked to pose on behalf of a core participant. Given the impact of long COVID on educational attainment, have you provided advice to the Department for Education as the Chief Scientific Advisor on long COVID in children and the impact on education?
As Chief Scientific Advisor, my advice is responsive.
Is that a no you've not been asked to?
My lady, I'm just trying to recall the Civil Service Code. I'm not a civil service. servant. I work in the civil service, but I'm not a career civil servant. And I believe I'm just trying to work out whether it is reasonable for me to talk about the advice I give. Does that make sense?
Yeah. Professor Viner,
I think...
You're not giving legal advice. I can't think of any reason why.
I think part of the
No,
civil...
at the moment, the question simply is, have you given any advice? Forget about the content.
I don't believe I have been asked to... Oh. Have I been asked to give specific advice about that outside of the COVID inquiry? No.
thank you. I'm going to ask you now about the impact on children and young people of COVID more broadly. You carried out a systematic review of the impacts of school closures on the physical and mental health of children and young people. And that review concludes that school closures are associated with considerable harms for children and young people, their health and well-being, and that more data is needed on the long-term harms. Can I ask whether that data has been produced on the long-term harms? Do you know?
I think there is now a plethora of data on long-term harms, much of it of low quality, particularly when conducted during the pandemic, but some of it of higher quality. This systematic review was something that I started collecting data on from, I think, May or June 2020, so very early on. It was prompted by some work I did with the World Health Organization. Our concerns about harms had actually started before that, if I could answer at length.
Please.
When I was Royal College president, it started to become clear to us that harms were accruing to children in many ways, in part because of policy. We published a paper, in fact, having done a survey of thousands of paediatricians. We felt we had evidence that more children had, at that stage, died from not attending hospital for other conditions than had died from COVID-19 at that stage. That there was significant fear that parents, if they took their children to hospital, they would either catch COVID or the children might be isolated and taken away from them, and a lot of anxiety. So the messaging of stay home, save the NHS, had some harms for children. And we communicated that very much to the Chief Medical Officer and to others, and there was some change in that policy and in the way that NHS 111 worked. We also started to see a range of harms coming in terms of suicide risk for children and young people, and some reports around child abuse. Essentially, we dismantled the safety net around our children, and we transferred child health and social care professionals to look after adults. We did that in an emergency, I think in some senses without really thinking what we as a nation did. I think we didn't have a recognition of how complex and important the safety net around children is, and how much schools are part of that. And that started to become clear that there were harms really from quite early on.
The kind of harms that you've talked about are delayed presentation and suicide risk. Are there any other harms that came to your attention in your systematic review?
So extraordinary levels of harm. So delayed presentation right across all physical health conditions and mental health conditions. So that was a real concern. There was harm in terms of social isolation. That was leading to the mental health harms, not for all, but for many, and also a lack of sight of vulnerable children. Again, that's dismantling of the safety net. Mm-hmm. There were also harms to physical health because of sedentary behaviour, higher screen time, lack of physical activity, rising rates of obesity. It was almost every part of children's lives. And child development, some suggestion of delays in development. Early on in the pandemic, we have very little data on that, but I think some of those data have emerged since.
Yes. And can you tell us, as a professor of adolescent mental health, that impact of isolation for young people during lockdowns and being in the home with their families, not socializing with their peer groups, what impact did that have on their adolescent development?
So just a minor correction, so I'm professor of adolescent health but I do quite a lot of work in mental health.
I'm sorry. My error.
For young people, adolescence is the time where our neuroscience colleagues have showed us that the social brain is rapidly developing and highly sensitive, and we know that young people in particular are vulnerable to social isolation. It's true that not all young people suffered during the pandemic in terms of mental health. There were small groups of young people who enjoyed being at home. But for the great majority, this was a clear harm to their mental health, and we saw rises in young people's mental health problems in the survey, the first national survey that was done during the pandemic, published in October. But this has been replicated in many other studies. There is a little bit of debate about this, about how much the lockdown was to blame and how much other things are to blame. But academics will debate.
Yes, of course. I'm going to move on now to your reflections and recommendations for the future. In your witness statement, you say that in a future COVID-like pandemic, the impacts on children and young people need to be better balanced against the protection of adults from serious disease or death. Is that right?
Absolutely.
Do you have any recommendations for how that balancing ought to be done?
I believe, firstly, that there should be clarity about who is responsible and speaking for children and young people at a national level during a pandemic or a national crisis. I believe that modelling should be expanded to, if it can, include thinking about the harms. Modelers are generally modelers of infectious diseases tend to think very much about infectious diseases, and those who model, and there are some who model mental health and others using newer modeling techniques, are often from very different tribes. There are some attempts to pull this together within the modeling world, and I think that should be strengthened. But my modeling colleagues tell me it is difficult to fund research in this area after the pandemic. So that would be important. I believe we should have an appreciation of how complex the web of social protections around children is, and how fragile it is, and how easy it is sort of rent by shifting health visitors, social workers, and others out. And how closing schools doesn't just impact on education or disease control, but impacts on our ability to see vulnerable children and impacts upon the social lives, social development of all children and mental health of all children. So those recognitions. More recognition. I believe it's important to think about children specifically within government policy. Child health advocacy organisations have a slogan which is child health in all policies, which was a slogan we had at the Royal College. But that's simply a message to say it's easy to think about adults mostly because they're 78% of the population, and it's easy to forget about children. But there should be mechanisms to stop us doing that. Or there already are some, but they need to be strengthened.
Yes.
And I also think that communication to children and young people is important. This is something that when I was college president, we tried to convince ministers to do, as did the Children's Commissioner, to run some press conferences for children and young people, as they did in a number of other countries, but we were not able to be successful in that.
Thank you. I've just one final matter, and it might be a matter which is not within your expertise, and if that's the case, please just say so. You made comments to the Independent newspaper that schools should be made safer, and identified that more should have been done to improve ventilation facilities in classrooms. In your view, did the government do enough to protect against airborne transmission of COVID-19 in schools, particularly for clinically vulnerable children and children in clinically vulnerable families?
Remembering that Professor Noakes is coming next.
Yes.
I would bow to Professor Noakes's expertise on this, and this is not my area of expertise. I increasingly recognise the importance of ventilation, and I think I will say that's not my specific area of expertise. I've not published on that area.
Okay. Well, thank you very much. We will hear from Professor Noakes later on this morning. That concludes my questions for this witness, my lady.
Thank you very much indeed, Ms. Bottle. Mr. Wagner, who's there?
Thank you. Over here.
Oh.
Sorry.
That's right.
They're saying over here doesn't actually help very much either. Thank you and good morning, Professor Viner. For clinically vulnerable families, which represents the interests of clinically vulnerable and clinically extremely vulnerable and immunocompromised families. I want to ask you first, please, about the impact of school closures on transmission rates, and particularly those systematic reviews that you were involved in. Would it be fair to say that many of those studies that you reviewed that suggested schools were not a major source of transmission focused on data obtained during 2020 to 2021, where schools were partially or mostly closed, and also that there was a very significant other factors that needed to be taken into account, particularly that people were living much more restricted lives?
The Transmission Systematic Review, which ended up being published, I think, in December 21, included data from across the pandemic. So some of those studies were when, in some of those countries, I believe, when schools were maybe partially closed. So that's not unreasonable to say. However, the striking thing about that systematic review was that the overall rates of infection in schools and the data on transmission within schools was strikingly low, particularly when compared to community. We found that transmission from children in community settings, household settings, was not appreciably different to that in adults, but it appeared to be significantly lower. The transmission rates in school settings seemed to be much, much lower, and that was difficult to understand. And much of that data, for example, from New South Wales, who did a series of really important and very well done studies, were actually when schools were entirely fully open, I believe.
I want to ask you about child mortality and severe health outcomes. Is it possible that the lower recorded instances of child mortality and severe health outcomes may have been affected by the way that clinically vulnerable children were shielded by their parents, so were prevented in many cases from going to school or from engaging even in the socialising that was permitted at the time?
There is certainly a possibility that's, I think, very difficult to prove or disprove.
Yeah.
But
Sorry, go on.
we also know that transmission is from parent to children is probably highest in within families.
Yeah.
And the degree to which shielding is very effective is, again, I think, unclear. But I think it's a very reasonable point you make.
And I suppose that you also have to, whether the parents of clinically vulnerable children were themselves effectively shielding to prevent that household transmission. Is that fair?
It was outside the data that we had, so I probably can't comment. What we found, I'll leave it there.
Once vaccinations were made available, is it fair to assume that many families of clinically vulnerable children would have had their children vaccinated before returning to school, which again may have reduced the mortality and severe disease rates amongst those children?
If I recall, our study of mortality took vaccination into account. Our study of risk and mortality took vaccination into account. We also have more recently published data on vaccination and how protective vaccination was in children with significant neurodisability, finding it had some protection, but relatively limited.
Different topic. I want to ask you about schools, and particularly children and clinically vulnerable children returning to schools, and also children from clinically vulnerable families, so children who were themselves not clinically vulnerable, but that one of their the people in their household were. Would you accept that it's almost self-evident that children and adults with underlying health conditions were the most at risk from severe outcomes of COVID-19?
Yes, with very specific conditions that I mentioned before. But yes.
And do you also accept that household transmission often occurs between children and adults? I mean, you've already mentioned that as an important factor. And do you agree that in many school environments, it would have been, realistically, would have been difficult to prevent the spread of COVID-19 because of the issues, well-known issues with social distancing amongst children, lack of good ventilation, lack of masking, those sorts of issues?
I think we get back to the question of whether school environments are major drivers of the pandemic or not. And I think the evidence from all of my papers over time pulls together to suggest that schools were not major drivers of the COVID-19 pandemic. That our assumptions, everyone assumes they must be. We put lots and lots of children together, they're a bit snotty, they, touch each other, they play together, they must be, schools must be drivers of infection. That's our underlying assumption and was. But it's not particularly supported by the evidence. It's not supported by the evidence for this condition in general.
Well, I mean, there's slightly two separate questions, whether schools are a major driver of infection and whether schools are a driver of infection, whether it's possible.
They're a place where infection happens.
They're a place in the same way that any indoor environment during the pandemic would be. Is that
probably not any indoor environment? I think there was some evidence, and I'm not an expert on indoor environments. You're going to hear from Professor Noakes soon. But I think there was differential for different environments that really drove pandemics.
Yeah.
But I think, sorry, I should let you ask your question.
Well, just to clarify what I'm asking you, I'm not asking you about the overall picture of whether schools should be closed, whether they should be partially closed. It's more about from the perspective of those clinically vulnerable families. Would it be fair to say that schools are certainly not a risk-free environment during the pandemic particularly when there's high community rates? Is that a fair proposition?
I don't believe that schools are ever a risk-free environment, but I don't believe any environment is risk-free.
Yeah.
So I find that difficult to answer. It's impossible to make schools safe. It's only possible to make them safer.
Yeah.
We accrete risk into our lives. A parent leaves their front door with a child. There's risk involved in everything they do. There is risks to children from going to school in normal life. We should do everything we can to make those risks lower.
And in light of the fact that you can't, not only can you not eliminate the risks, but some schools are going to be safer than other schools because of the fabric of the building, ventilation, those sorts of things. Would you agree that clinically vulnerable children and children in clinically vulnerable families would have had, during those acute phases of the pandemic, legitimate concerns about the risk of returning to in-person education?
If those children were truly clinically vulnerable, absolutely. And I recall when college president that there was a process with NHS England to really try and be clear about which children were truly clinically vulnerable or not, because there were assumptions made at the beginning of the pandemic that where our knowledge changed.
Yeah.
And so it was very important to be specific.
Yeah.
And for those children, where their paediatricians had been involved and they're very specifically clinically vulnerable, absolutely, we need to be much more careful about them, protecting them.
And equally, there will have been a lot more adults who are clinically vulnerable, genuinely clinically vulnerable, severely clinically vulnerable, living in households with children who weren't, than the other way around. Is that fair?
I believe so.
And they would also have legitimate concerns about the child going back to school and then coming back with COVID. Is that a yes? Sorry, I didn't hear.
It's a reasonable concern, absolutely.
You wrote an article on the optimal strategy for reopening schools in August 2020, published in
Yes.
The Lancet. And you concluded that reopening of schools in the UK must be accompanied by large-scale population-wide testing of symptomatic individuals and effective tracing of their contacts, followed by isolation of diagnosed individuals. And you also said that full school opening without an effective test, trace, isolate strategy would result in a second wave of infections that would be 2 to 3 times the size of the original COVID wave. Is that a fair summary of some of the conclusions?
I would just absolutely with the substitution of the word could rather than would,
Yeah.
because the modelling studies are purely speculative.
Right. Did you believe that there was an effective test, trace and isolate system in place in UK schools when they reopened in September 2020?
I don't know that I can answer that question. I can't recall the state of test and trace at the time. So I don't think I can answer that question. But the intent of that modelling study was to examine what could prevent a second wave and keep schools open. And then we found an effective test and trace system was. I don't think I can go beyond the science.
And if there wasn't a functional test, trace and isolate system in place at that time, would that have been a reason to delay the reopening of schools, in your view?
I understand your point. I believe that everything else at that time told us that schools were safe to reopen. And in fact, indeed they were until the Alpha variant.
Until they weren't.
Until the Alpha variant changed everything.
Yeah. Okay.
But that was unpredictable. But in the knowledge we had of the wild type variant, which is when schools were reopened, we actually had good pandemic control, I understand. And they were reopened without a major second pandemic wave.
Thank you.
Thank you, Mr. Wagner. Mr. Jacobs. Mr. Jacobs is that way.
Thank you.
Good morning, Professor. A question or two on behalf of the Trades Union Congress. In your statement, you reflect on the lessons to be learned in a future pandemic, and you describe that the government should begin with a presumption that school closures will be harmful to children and young people and to the national interest, and that they should only be used as a last resort. The first bit of that, the presumption that school closures will be harmful to children and young people, is clearly uncontroversial, and I suspect from your evidence you would say it's not so much a presumption as a certainty. I want to ask you a little bit about the second bit of your recommendation, that as a presumption, school closures should only be used as a last resort. Professor, perhaps the one certain thing about the next pandemic is that the virus will be different in terms of its characteristics to the last, and I think in your statement you make an observation to similar effect. Are there scenarios, to your mind, in which closing schools, rather than being a measure taken at the last possible moment, may be something actually to be done at a comparatively early moment?
So my feeling that a last resort doesn't mean it's done late. I think a last resort would be maybe that's shorthand for saying something that is done only when forced into a corner, and that is done with and some of the subtext behind that is that we don't close schools before we close pubs. Is a lot of the subtext behind that. I absolutely think you're right, to answer your question, that there may be scenarios, and a scenario in which a virus or a bacteria, likely to be a virus, was specifically infecting children, and children were the super spreaders, you may put school closures in a different place. I think from a a moral and ethical point of view, it would be very difficult to lead with school closures while other parts of society remained open. Hospitality, pubs, etc. I would find that, I suppose we're getting into moral and ethical issues here rather than science, but.
So, Professor, it sounds like you would agree with me that however My Lady chooses to express it, it needs to be clear that last resort doesn't necessarily, as you put it, mean late.
No.
And just to sort of tease out why that might be so, I think you've mentioned potential differences in terms of transmissibility and no doubt rates of fatality in children, which may, of course, be different in the next pandemic. Might it also be that earlier restrictions may ultimately, depending on the virus, depending on the level of preparedness, may ultimately lead to fewer restrictions in the long run?
Absolutely. There is an argument to be made that earlier, shorter restrictions and a range of different types of restrictions. There was discussions of the 2 to 3 week half terms, of fire break lockdowns, a range of different things. Some of that is beyond my expertise. But long sustained lockdowns are undoubtedly harmful to children.
Yeah. If I could just test My Lady's patience with one final question. With your insight, Professor, into how government decisions are made and some of the challenges, is a recommendation of closures only as a last resort potentially a bit misleading, given that in particular circumstances, bold and early may be absolutely the right thing to do?
The key issue, I think, is to recognise the extreme harm that comes from school closures, and that they are never a consequence-free decision. Governments tend to pull levers that they can. One of the things I would observe is that governments have a strong degree of control over children's lives in a way they don't over adults. We control children's lives in multiple ways, and one of the ways we control children's lives is through school and school attendance. And we need to be very careful about how we use those levers, because they are relatively easy to pull. And so the real caution about school closures as a potentially easy lever to pull is, I think, the gist of my recommendation, that they have extreme consequences. There may be scenarios, as we've just discussed, in which we do that for the benefit of the child themselves. In the COVID-19 situation, the school lockdowns were very largely for the benefit of adults.
Professor, thank you very much.
Thank you, Mr. Jacobs. That completes the questions we have for you, Professor Viner. Thank you very much indeed. It's been a very informative and interesting session with you. So thank you for the help you've given.
Thank you.
Very well. I should take the morning break now and return at past. Bye. Ms. Bottle.
My Lady, may I please call Professor Catherine Noakes?
Repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Seems like a lifetime ago since I thanked you for your help last time, Professor Noakes. Thank you for coming back.
Thank you.
Professor Noakes, you've provided a helpful witness statement to this module of the inquiry. It should be in front of you there. The reference is INQ 000588180. Is that right?
Yes, that's correct.
Professor Noakes, you are a professor of environmental engineering in the School of Civil Engineering and the Pro-Dean for Research and Innovation in the Faculty of Engineering and Physical Sciences at the University of Leeds. Is that correct?
Yes.
You are a chartered mechanical engineer with a background in fluid dynamics. You are a fellow of the Royal Academy of Engineerings, a fellow of the Institution of Mechanical Engineers, a fellow of the Institute of Healthcare Engineering and Estate Management, an honorary fellow of the Chartered Institute of Building Services Engineers. Is that right?
That's correct.
Your research has focused on the environmental transmission of diseases in the built environment, with a focus on exposure to pathogens in air and on surfaces, as well as the role of engineering approaches and behavioral and management responses to mitigating transmission. Is that correct?
Yes, that's correct.
In your statement, you explain briefly what fluid dynamics is to the uninitiated. Can you just help us and give us a brief summary of what the study of fluid dynamics is?
Yeah, so fluid dynamics is the understanding of how fluids, so liquids and gases, move. And in the context of disease, that includes things like ventilation of buildings, it includes the droplets and aerosols that people produce. But the study of fluid dynamics also applies to things like the weather, blood flow in the body, how car engines work, etc.
And if we think about the transmission of COVID, would fluid dynamics be relevant not just to airflows in buildings, but also how aerosols are expelled from the body into the environment? Is that correct?
Yes, that's correct. So fluid dynamics describes how when we breathe or cough, how those fluids inside our bodies are released and might be released into different sizes of aerosols or droplets.
Can you tell us briefly about your involvement in the COVID-19 response?
I was involved in a number of ways. So in April 2020, I was approached to be a participant in SAGE, and I was also asked to set up a subgroup called the Environmental Modelling Subgroup, and that was a major part of my activity during the pandemic, and I think you've heard about that quite extensively in Module 2. I was involved in a number of groups nationally and internationally who were concerned with transmission of the virus and the ways to mitigate that, and both looking at the research evidence there and the sort of practicalities of mitigation measures. And I was also involved in a number of research studies that were commissioned or requested during the pandemic to look urgently at a number of aspects relating to transmission and mitigations.
Yes, we'll come on to a couple of those particularly relevant research studies in a moment. But can you help us with your role as regards the Department for Education? You were the chair of the Environmental Modelling Group and a part of SAGE. Did you also provide advice to the Department for Education directly?
Yes, so I had a number of interactions with the Department for Education. Many of those were sort of ad hoc, small meetings and by email with mostly with technical civil servants in the engineering or energy aspects of Department for Education and their science team. And again, looking at some of the practical aspects around transmission and mitigation, particularly thinking about school environments. I did one or two other things as well. I recall doing at least one sort of webinar type session for civil servants, and I think I had one meeting which was with more senior stakeholders.
Your highly specialized expertise was clearly in demand, I suppose, during the response to the pandemic. Would that be fair?
That would be fair, and it was not just for Department for Education. Most other government departments had the same questions.
I see. Can you tell us briefly what is known about the route of transmission of COVID-19?
So we know it's a respiratory transmission. At the early days of the pandemic, the specific mechanisms were unclear, but it was still early days recognised that respiratory transmission means the virus is emitted from people's exhalations, and that will be in the form of very small particles. That can be transmitted essentially in 3 different ways. It can be transmitted directly through the air, where people inhale that virus. It can be transmitted through deposition onto surfaces. That might be direct deposition from particles or from coughing on hands and touching surfaces, so potential for that route. And then also potential for much larger droplets, like when people cough, to directly hit mucous membranes. Over the course of the pandemic, our understanding of that transmission changed. I think you'd be well aware that at the outset, the focus was on washing hands and cleaning surfaces. Over, I guess, in 2020, the evidence built for the importance of airborne transmission, and I suspect now that the majority of transmission is through direct inhalation, whether that be at a longer distance in a room or whether it's at short distance, it's inhalation. Most likely is the primary route of transmission.
And at a high level, can you tell us how does that inhalation route impact on infection prevention measures?
So the inhalation route will depend on where you are with respect to the infected person. So if you're sharing the same room and you're at some distance, then those particles, which tend to be very small at that point, could be inhaled from the air, and therefore measures such as ventilation or air cleaning or disinfection technologies are the most effective mitigation measures. At close proximity, so when you're within about 1 to 2 meters of an infected person, the ventilation has much less of an effect. It's not to say it has no effect, but it's a lot more uncertain. And other measures like keeping a physical distance or wearing masks are effective there. Of course, wearing masks, if you are the infected person and you're wearing a mask, that limits how much is spread into the room in the first place. And if you are a susceptible person and you're wearing a mask, an effective mask, then it can reduce how much you breathe in regardless of your distance.
And you've already touched on this, but can you explain to us, for people who are not very close to each other, so more than sort of 2 meters away, how it is that ventilation mitigates against transmission?
So ventilation, if a room is ventilated effectively, is about the exchange of air in that room. So it's about providing outside air that we often term it as fresh air to that space, and using some form of exhaust, whether it's a window or a mechanical system, to remove contaminated air. So a room that's ventilated, typically that ventilation will act to dilute any particles in the air, which will include the virus. So it reduces the concentration and act to remove them from the air over time.
And I suppose reduces your chances as a susceptible person from breathing in contaminated particles.
Yes, absolutely.
Because it's more diluted. Okay. And can you tell us, just at a high level, how air cleaning works, at least in theory, to mitigate transmission?
Okay. So there are 2 different technologies for air cleaning which have been recommended. One is using filter-based devices, and you have some of those in this room, I see. And these essentially are a box typically about 1 meter tall. They have a fan within them, and then they have a very high efficiency particulate filter. They draw the air through, and viruses and other particles in the air are physically trapped and removed from the air by that air cleaner. There is another technology which is shown to be effective called ultraviolet air cleaners or air disinfection units, where they, either within an enclosed box or sometimes in an open environment, pass virus or bacteria through a field of light created by these UV lamps, and that inactivates the virus or the bacteria. So it doesn't physically remove it, but it renders it harmless, essentially.
I see. And just pausing there, I suppose it follows from what you said that other particulates
in the air, for example, caused by mold or air pollution, would be removed by a filter, like
Yeah.
a HEPA filter.
Yes, that's correct, yes.
But if we're talking about UV devices, then they wouldn't have an impact on those other particulates in the air.
So UV only impacts on biological particles, so they will have some effect on mold, as mold is a biological particle.
I see.
But they won't have an effect on an inert particle.
I see. Before I ask you about the strength of the evidence on the effectiveness of ventilation and air cleaning on infection transmission, I'd like to ask you briefly about two studies in which you were involved, the CVOS study and the Class Act study. So if we begin, I hope I'm pronouncing it correctly, with the CVOS study, can you tell us what that study investigated and what your role was?
So that study was supported by, initially by the Department for Education and the Department for Health and Social Care through their Test and Trace programme, and then was part of the Protect National Core study. It had two phases. The first phase was to put blind CO2 monitors in schools, so these didn't have visible displays on them, but put them into schools to record data in classrooms in 4 schools to get an understanding of the concentrations of CO2 in those schools, and hence a baseline understanding of the ventilation fluctuation in those schools. The second phase of that study was about putting the visible monitors into schools and to look at the response of the schools to those monitors. And that actually coincided with the rollout of the monitors into schools by the Department for Education.
And am I right in thinking that the study showed the importance of the behaviours?
Yes.
You tell us.
Yes, so the study showed, well, first of all, it showed considerable variation in the CO2 concentrations, both between schools and within the same school. And it showed the same different variation over the course of the measurement period. And as an example, we measured, at the beginning of the study, we had quite a cold period where we saw reasonably good CO2 levels. Towards the end of the study, we saw another cold period, similar outdoor temperatures, but showed worse CO2 levels. And that would suggest to us that given the outdoor conditions were similar, there was a change in the behaviours in the school. And that may be to do with people being less attentive to things like opening windows in those cases.
And are we talking here about that second phase where there would have been CO2 monitors with a display for individuals to take action?
So no, that was the first phase, so we didn't have that information at that point.
I see. Okay. Did that study show the barriers in schools to achieving good ventilation?
It did show some barriers, yeah. It showed some essentially challenges with understanding of the CO2 monitors. It showed challenges with people finding the time and the inclination, I guess, to think about ventilation. And if you're a teacher in a classroom, your primary role is there for education and the well-being of the children in your class. And you've got a lot of things to do, and you're not really there to be an expert on ventilation. And so actually putting this additional requirement into school classrooms and to teachers, and it you know, with something like a CO2 monitor, it does fall to a teacher because it's there physically in the classroom for them to do something about.
I think I've gotten ahead of myself slightly. The first stage of the study, there were CO2 monitors that didn't show what the readings were.
Yes.
The second stage of the study, there were CO2 monitors that showed the readings.
Yes, yeah.
And in that second phase, did you still observe variations in CO2 levels in classrooms?
I can't recall exactly what we thought. There will have been, yes, because you always see variations.
I see.
It varies depending on the weather, depending on the day of the week, depending on the behaviours in the classroom.
I see. Did once you were in the second phase and teachers, for example, in the classrooms were able to see the different CO2 levels in their classrooms, did the study show that having that input, if you like, that sort of technological input, did that help teachers achieve better conditions for ventilation in their classrooms?
I think it did. Certainly we got some input from teachers who felt that it had helped them to understand things better and to see things. Bear in mind, this was a very small study, a small number of schools. I am aware from that and other studies that there are still challenges in some classrooms. If your CO2 monitor shows poor conditions, yet there's not much you can do about it. You know, you can't open a window or for whatever reason. It becomes a bit, I guess, demoralising if you've got something that tells you something's poor, but you can't change it.
I see. So the provision of CO2 monitors in that study didn't show that this was a sort of silver bullet for fixing ventilation problems in classrooms?
No, it showed it was a useful tool, but it's not a silver bullet by any means. There are no silver bullets.
Okay. I'm going to move on now to the Class Act study. Can you tell us what that looked at and what your role in that study was?
So within that study, that was a study that was funded initially from the Department of Health and Social Care, involved Department for Education. It was across a number of universities. I was one of the co-investigators in that study, so I was not the study lead. That study aimed to look at air cleaning devices in classrooms and aimed to look at a number of factors, including the practicalities of them, including their effects on the air quality in those environments, and also the effects on absence due to illness. So the study involved 31 schools in the Bradford area. 11 of those schools are what we termed a control group, so they didn't have any interventions. 10 of the schools had HEPA filter-based devices in them, and 10 of the schools had ultraviolet-based devices in them.
I see. Can you tell us that there were 2 phases to that study as well? Phase 1 of that study, the results have been published. What did they show?
So the initial phases of that, the results that have been published from that, we have some modelling results that have been published. We have some very early data which showed the devices reduced the concentrations of particles in the air. We are still working to publish the findings around infection transmission, but we identified that the schools with the HEPA devices had a lower rate of illness absence in those across the average across those schools.
I see. In your witness statement, you explained that the publication of those results about the reduction in illness absence has been delayed because of the delays in the peer review process. But in your view, can we still have confidence in the results that the study did show reduction in illness absence?
Yes, so I am confident that in those results, we've just not managed to publish them yet through the journal peer review processes, which can be quite long-winded.
Okay. Now I'm going to ask you generally, not just looking at those 2 studies, but in your position as an expert in this field, what is the strength of the evidence for ventilation and air cleaning to reduce the transmission of infection?
So I guess to start with, to say that ventilation has been a measure for decades to reduce the concentrations of not just microorganisms or viruses, bacteria in there, but also other pollutants in the air. So from a physics perspective, it's very straightforward to show that ventilation reduces the concentration of contaminants in the air. It is a little bit less straightforward to directly show that it reduces infection transmission. That's not to say that it doesn't. I think there's just very few studies which have attempted to measure it.
Yes. In your witness statement, you set out, and this is at paragraph 6.8, that there are limitations in the evidence specifically for the transmission of illnesses, for the effect on the transmission of illnesses. And you set out sort of two reasons for that, for the limitations. And those reasons are firstly that there's not a linear relationship between reduction in pathogens in the air and a reduction in infection rates. Have I understood that correctly?
That's correct, yes.
Okay. And the second reason you give is a bit more complex, at least to a non-scientist, but seems to be that it is very difficult to measure the impact on illness because these are environmental factors. And for instance, if you had children attending school with an air cleaner, they would still be traveling to school on the bus, and they might be infected in another environment, and it would be difficult to separate out the impact of measures in the school from other environments that they would pass through during the day. Have I understood that correctly?
Yes, that's correct. And I think, it's fair to, just because those studies don't exist, or there is a small number of them, doesn't mean that this, the devices or the ventilation doesn't have an effect. I think everything that we've seen points to the fact that it is beneficial. But you're right, it is difficult to measure because you have many confounding factors. If children are, you might have a classroom environment which has been improved, but then if they're sharing, the bus, or they're going to the same social activity after school, and that hasn't been improved, then they may well still get infection there. And certainly there have been studies, historical studies, where that confounder became a challenge.
Now, so far we've been talking about the strength of the evidence for ventilation to reduce transmission. Is the position the same with the strength of the evidence for air cleaning to reduce transmission in infection?
I would say that there is probably more evidence out there for ventilation, simply because it's been studied for longer. But that, if I go back to basics and the principles of physics, whether you remove those particles from the air by diluting them and ejecting them outside, or whether you might remove them by trapping them in a filter, you are doing the same thing. You are reducing the concentration of those particles in the air, and therefore there is no reason why air cleaning shouldn't be as effective as ventilation if it is applied correctly. I think it's worth noting, though, that air cleaning doesn't tackle other issues that ventilation is important for. So we've talked about CO2, as well as being a marker for the amount of ventilation in a room. It is also, there is data to suggest if you're exposed to high CO2 levels, it affects your concentration, it makes you a little bit sleepy. We've all been in a meeting room where we've fallen asleep a bit and it feels very stuffy, and that's usually a poorly ventilated space. And if you put an air cleaner into that space, whereas it will remove some of the contaminants in that air, it won't tackle that aspect. So in my view, air cleaners are a useful tool, a very useful tool, but they are no substitute for good ventilation, which actually is important for many other factors.
And to look at it a different way, would I be right in saying that good ventilation is sort of the gold standard, but if that can't be achieved for a particular reason, air cleaning could be a good mitigation tool, but it doesn't replace good ventilation?
Yes, I would agree. It can supplement ventilation, and it can be, it is an easier measure to implement, particularly in a short term, whereas improving ventilation can be a longer term and more expensive approach.
Okay. looking again at the state of the evidence and the limitations on obtaining good quality evidence for these measures, are these limitations ones that could be overcome with further research and funding, of course, or are they limitations that are inherent in the field that we'll never be able to resolve?
So some of those limitations could be overcome with more extensive studies. I do mention in my statement that studies around environmental interventions have historically not attracted much in the way of research funding. You know, and they are not like a clinical trial. You know, I think people perceive them to be like a clinical trial, and you know, we intervene in one place and we don't intervene in another place, and we switch things over. You have to recognise the environmental factors that play into it, and that your intervention might behave differently on different days of the week, which is very different to, say, a drug intervention. Mm-hmm. But that's not to say we couldn't design studies to do it. To get those studies, we need a scale of studies. It's a highly interdisciplinary team that you would need to do those studies, because you need both the sort of engineering and environmental expertise along with the epidemiology, the statistics, the understanding of disease, and all the behavioural science aspects of it as well. And of course, we're talking about interventions in real environments where people are busy. So this is not perhaps like a clinical trial where you might sign up and you might go individually to a hospital to experience treatment or something. You're putting these into classrooms in schools, and then you're requiring researchers to go into those schools. And those schools are busy environments, as I say, who've got other things to do. So actually finding ways to enable that research to happen is also part of how you design those studies better.
I see. I'm going to ask you now about the specific features of schools which impact upon transmission risks and mitigation measures. You set out in your witness statement at paragraph 5.6 the specific features of schools that impact on transmission risks. Can you just talk us through those?
Yeah, could I
Yes, of
ask
course.
for it to come up on the screen so I can remember what was in there?
Yes, of course. It's not a memory test.
Sorry, I found it here in my. So I think it's fair to say that schools are not a uniform thing. We've got both children and adults in there, and depending on the school, you've got different ages of children in there. So there will be a range of different vulnerabilities in there. So and we know that whereas the COVID is usually milder for children and for most children, we do know that some children may be much more vulnerable to its effects. And we also know now a lot more about long COVID and the importance of that. The adults that work in schools, I think, again, they may be much more vulnerable than the children, particularly COVID. A different disease, that might be the other way around. I think I noted about it may be hard to identify who's infected, particularly young children. It's very hard to do swab tests on very young children, and it's very hard to necessarily distinguish whether a sniffle is COVID or just a cold. I think the environments are quite specific, and again, my focus is very much on the built environment, but they do bring people together. So they are one of the, in an environment, they're relatively rare. If you think about a workplace environment like an office, yes, they bring the same people together, but people come from quite dispersed in offices. Mm-hmm. In schools, they bring the same people together day after day for quite a long period of time in quite congested spaces. And I would say school environments are one of the most densely occupied buildings that exist, with the exception of certain really crowded spaces.
I see.
And they facilitate different activities. So you've got some activities like sports going on, you might have music going on, you've got all sorts of different things going on that might make transmission more likely. You've also got children who may interact very closely as well as sitting at distances apart. And they connect up communities. So there's a lot of reasons why schools are particularly distinctive, I think, when it comes to thinking about disease transmission.
And I suppose it would also be the case that in schools where you have these different age groups, children and adults attending, unlike, for example, in an office, there might be differences between the ability to apply other infection control measures. For example, masks in young children are generally not advised because of their ages. That's a feature of schools that you wouldn't have, for example, in an office building.
Yes, that's true. And you might have different levels of understanding depending on the ages, whether that's masks, whether it's distancing, whether it's hygiene.
Can I ask you whether ventilation systems are likely to be different in schools than in office buildings, for example?
So ventilation systems in schools vary significantly. The majority of schools in the UK are naturally ventilated or predominantly naturally ventilated, and that means they're ventilated via opening windows. Some schools have mechanical ventilation systems, like this room here does, but that tends to be a smaller number of schools. The quality of the ventilation varies significantly, as does the design of the buildings. So our schools range from Victorian era, small schools, through to modern day schools, everything in between. Some of them were built for smaller class sizes than we have now, so we've got more people in them than they were originally designed for. And I think it's fair to say that the maintenance of ventilation, whether it's mechanical ventilation or particularly windows in schools, is very patchy. There are certainly a number of cases where, whereas teachers might like to be able to open the window, there is a barrier to doing so, either because the maintenance is poor and it's been painted shut, or it's too loose in the frame and if you open it, it'll fall out, or actually opening the window represents a security or safeguarding issue with children being able to climb out or drop things out of it.
Yes. I'd like to ask you now about the real-world experience of STAR Academies. So they're a multi-academy trust. And we heard evidence earlier on in these hearings from Sir Hamid Patel, who's the Chief Executive Officer of STAR Academies. And he gave us some insight into improving ventilation in schools in his trust. Thank you very much. I'll just read out what he said. So where there was mechanical ventilation, that was straightforward. You just put it on a sort of clean air setting and that took care of itself. But where you had natural ventilation, that was a challenge. Because you were saying the only way to address that is to open windows, open doors, keep fire doors closed. So that is a practical solution. The CO2 monitors sort of had red, amber, green. So wherever there was red, a red setting, the schools would know that we need to open the window or we need to open doors. Very practical, but not sustainable. Because you've got a situation where you've got kids in, young people in coats in the classroom, or you're having to turn the heating on and open the windows at the same time. There is a point I would make on this, that there are many, many schools across the country that rely on natural ventilation. These are normally very old buildings. I do feel that there is a need to go and retrofit a solution, whether that's a mechanical ventilation upgrade or HEPA filters or something, because schools in disadvantaged areas are the ones that often have the poorest infrastructure. They are the poorest buildings, so a national ventilation standard for schools linked to health and learning outcomes would make a difference. I'm going to ask you later on in your evidence about building standards and your recommendations around those. But for the time being, does Sir Hamid's account of the barriers to maintaining good ventilation in schools with natural ventilation, does his account reflect what you learned in the CVOS study or your other professional work?
Yeah, I would largely agree with what he said there. It can be challenging, particularly in poor weather, to provide good ventilation in many schools and indeed in many buildings. And essentially they have not really been designed to provide good ventilation and comfortable conditions at the same time.
And how do you think that these barriers can be overcome in schools?
So I think as a short-term measure, it is not that easy. There are things we can do around improving the knowledge and advice that are given to schools around how to ventilate classrooms and improving that understanding of why it matters. We've touched on air cleaners already and HEPA filters, and I think obviously that is a measure that we can put in to classrooms and can be put in relatively quickly. Again, they will only be effective if they're used and they're used correctly, so that needs the right knowledge to go with it. Longer term, I do think I would agree with the evidence here that we need a better ventilation in many schools. Not all schools, some schools have perfectly good ventilation, but I think to identify the schools which have worse ventilation and a retrofit program. A retrofit program is not cheap, and therefore it would need to be designed well and funded for it to do it. But improving ventilation is not just about reducing COVID transmission. It's also about improving those environments for other respiratory infections, improving them for children who might have asthma, improving them in terms of the cognitive performance of children in schools and a learning environment. So there are much wider benefits to creating better quality environments in schools than simply just looking at COVID transmission.
Yes. And just before we move on from Sir Hamid's evidence, can we take it from his evidence and your answers that measures for ventilation which rely on human behavior are less reliable than, for instance, mechanical ventilation or air cleaning technology?
Yes, that's largely the case. If you have a mechanical ventilation system, provided it has appropriate maintenance and has somebody looking after it, that is usually far more reliable than a system where you rely on human behaviour to provide good ventilation.
Thank you. That can come down now. I'm going to ask you now about whether the government's approach to ventilation and air cleaning in schools was in accordance with the scientific evidence available at the time. I want to explore how, firstly, the understanding of the role of ventilation and air cleaning in transmission of the virus evolved from March 2020 through to January 2022, when air cleaning units were first provided to schools. So I'm going to read to you now from the statement of Julia Kinneberg. She provided a statement on behalf of the Department for Education. We don't need to pull it up, but the reference is INQ 000651498, page 132. Ms. Kinneberg says that the first mention of ventilation in DFE guidance was in July of 2020. And that guidance stated that ventilation should be considered in poorly ventilated spaces as part of any risk assessment and make sensible changes to increase ventilation, like opening windows and adjusting ventilation rates on mechanical ventilation. So that was the first advice provided to schools in July of 2020. And then a little over a year later, the Secretary of State for Education agreed to fund CO2 monitors in schools. And the statement records that this was after SAGE and PHE provided general advice confirming that ventilation remained important to reducing the transmission of the virus and that CO2 monitors could be a cost-effective way of helping to identify spaces with poor ventilation, and highlighted the use of air filtration systems. And what I want to ask you is, could CO2 monitors have been provided sooner? Was it known back in 2020 that CO2 monitors could identify spaces with poor ventilation?
Yeah, so looking at the first part of that guidance, I mean, I was first asked to join SAGE in April 2020. At that point, we highlighted ventilation as airborne transmission as a possibility and ventilation as a precautionary measure. I think by July, there was a growing recognition of airborne transmission, and so the advice given to schools in July was, and that was when there was some pre-reopening, sort of some of the schools went back in late 2020. Yeah. That advice at that point was appropriate. In the autumn of 2020, so I think it was September 2020, as part of SAGE EMG, we put together a paper on ventilation, and in that paper noted that CO2 monitors may be a useful measure. And then in November 2020, a paper on air cleaning devices from SAGE. So there was some SAGE evidence, scientific evidence around, in the autumn of 2020, around CO2 monitors and air cleaners. I believe that evidence initiated those discussions with the Department for Education and with the Department for Health and Social Care, Test and Trace, hence the two research studies you mentioned, which came off the back of those, into are these viable for schools? And obviously but then they were not really rolled out until the following year. Could they have come sooner? Possibly. I think it's worth recognising that, as well as saying this is potentially useful, there is a step between this is potentially useful and what does the specification of this thing look like, and can we procure enough of them? And so there is a specification and supply chain piece that has to happen. Mm-hmm. So although they may have been able to be provided to schools a bit earlier, I'm not convinced it would have been 12 months earlier, for example.
Okay. And I think you mentioned the study that took place between your advice in November 2020 and the provision of CO2 monitors in particular. Is that the CVOS study that we talked about?
Yes, so the CVOS study was one bit of, I guess, the evidence that Department for Education was looking at in terms of providing an insight into CO2 monitors. But they actually rolled out the CO2 monitors into schools before we'd completed before we'd actually really started the second phase of the CVOS study. So it was the evidence around the fact that CO2 monitoring gave insight into ventilation from the first phase of that study that was, I suppose, used to support the rollout of visible monitors.
In your evidence to Module 2, you stated that transmission via the air was not taken seriously enough, and the demand for more definitive evidence on that hampered mitigations being applied in a timely manner. Is it your view, in the context of airborne transmission in schools, that this hampered mitigations being applied in a timely manner?
So I think it's my view that hampered mitigation has been applied everywhere in a timely manner. I think that's almost a reluctance to recognise airborne transmission. And, you know, although international scientists, as which I was part of, raised it significantly in July of 2020, you know, the WHO at that point were rather grudgingly recognising it may be important. They didn't change their advice until significantly later. The UK Health Security Agency changed their advice on their web pages in, I think, September 2020. So, you know, I think it's not surprising to think that most environments, whether it was schools, whether it was workplaces, whether it was hospitals, were behind. I mean, the NHS didn't update their advice until I think it was June 2021. So that recognition of airborne transmission was slow across everything and across the whole world.
Okay, and just taking that point one bit further, What is your view on whether the government did enough to protect against airborne transmission of COVID-19 in schools?
I don't know whether you can ever have enough. I think that there was there was certainly intervention in schools. There was the intervention through CO2 monitors, through air cleaners. I'm not aware of other environments where there was that intervention at a systematic level. I think the challenges were more around the advice that's given and the recognising, the importance of ventilation within that advice, rather than the technologies. And I think, hindsight is the best bit of science in the world. If we were to go back, I think we would have perhaps not put so much emphasis on cleaning. We'd have not installed sinks. We'd have not put hand sanitizer everywhere. We'd have perhaps put that money into ventilation measures instead. But that, the evidence around airborne and the recognition of airborne happened, I suppose, too late for that to happen.
Okay. You mentioned advice that was given. Are you familiar with the guidance and advice provided to schools to use CO2 monitors and air cleaning devices?
Yes, so I'm familiar with that, and I saw some of that at the point it was being written.
Okay. In your view, was that advice and guidance sufficient to enable schools to use the CO2 monitors and the air cleaning devices effectively?
So the advice, I think, is technically appropriate. It's, it says the right things. I think it's not so much the content of the advice, the way it's delivered that's more challenging. So that advice, my understanding is it was provided to schools via a portal that only schools could access. So it was not publicly available. It meant that schools had to log on to some sort of system, I think, to be able to get that advice. And it was very much a written format advice. And I think it's not just about giving instructions, it's about people really understanding why this matters and why it's important. And I think that requires perhaps a different way of delivering advice. I think Department for Education tried to address that a little bit, and I only know that because they asked me to get involved in doing some little videos for their YouTube channel on ventilation and CO2 to try and put something out there that was a little bit more engaging and user-friendly. But I think, there's a difference between having advice that's technically correct versus how you actually get that to people and get that understanding and the right sort of training and knowledge that people will need to be able to put that advice into practice.
Yes, in your very helpful recommendations, I think you set out a recommendation about improving the sort of state of knowledge for schools about ventilation and air filtration. But before we move on to your recommendations, I have a question which I've been asked to pose by a core participant, and that is whether the UK government has sufficiently incorporated the Class Act study's findings into policies on making education settings safer.
So they certainly use the Class Act study's findings to inform the decision to provide a scheme for air cleaners in schools, which included, I think, rolling out, I'm not sure it was 7,000 or 9,000, but it's quite a substantial number of air cleaning devices, and providing, there is a web page that they put together, again, to provide advice on that. Again, I think whether that's embedded effectively, I'm not sure that has happened, but to embed things requires perhaps more funding and more long-term approaches to thinking about that. And I'm not privy to I'm not fully aware of what discussions are still ongoing in that space.
In your statement, you note that a barrier to engaging schools in research can be the capacity of schools because many are overburdened in terms of workload. Are there any areas in respect of NPIs in schools where you consider that more research is required?
So, I mean, I do believe we have sufficient evidence to be able to say that, for example, ventilation and air cleaners are effective. What we could still do with is a wider evidence base around how they're used, where they're used, and the variation in their effectiveness, because we don't have that data. We don't really have good quantitative data that allows us to use them to make predictions or things. So I do think there is still a need to collect evidence there. And then there are many things around hygiene, masks, etc., where the evidence base is really small. Again, but as I said, it's not so easy to conduct research with schools. Some schools are really good at engaging, and in fact, most schools want to be supportive of research. It's just that they've got many other things to do other than to help with data collection for researchers.
Yes. I'm going to move on now just to more broadly your recommendations. You've helpfully set out a number in your witness statement at paragraph 8. And I won't take you through all of those, but you set out, thank you very much, at paragraph 8.1, recommendations that you made in your module 2 statement, putting a greater level of investment into mitigating environments which contribute so much to long-term societal equality and long-term economic growth, such as schools, could be better prioritized. And 2, a program to improve environments in buildings alongside other public health system interventions would likely improve resilience to future pandemic risks, including reducing inequalities, as well as bringing wider health benefits. Can I ask you, how does ventilation and air cleaning fit into those recommendations? And do you support investment in those now?
Yes, so I mean, I think we've talked about the fact that schools and actually many public buildings have quite patchy ventilation. Some are very good, some are less good. I think the evidence base is all pointing in the same direction, that better ventilated environments provide a healthier environment for children and adults. They help you mitigate against disease. They help you mitigate against other respiratory conditions. If those environments are designed well and they're thermally comfortable, they create better quality learning environments. And of course, children, this is such a formative point in their lives. Providing the best environments for those children should be really important. I think it's worth noting that even if we comply with the current standards for school ventilation, that is still at the very bottom end of what's recommended by HSE as adequate ventilation.
Yes.
So I don't,
Sorry,
and
I
I jump in the gun.
ask you, yes, that was to be my final question for you on this topic and your evidence, which is, you set out at paragraph 8.42 recommendations about building standards. Oh, thank you very much. So you say school ventilation in new buildings or major retrofit is covered by Building Bulletin 101. That's a document owned by the Department for Education,
Yes.
Is that right? Yeah. It was last updated in 2018. This guidance includes recommended CO2 levels as a proxy for ventilation, but the values are considerably higher than recommended for other buildings. The guidance should be revised to both reflect new evidence, including changes to the building regulations and new research since the last revision, and to ensure that children and staff in schools are able to access ventilation that is designed to be at least compatible to standards for other environments, such as workplaces. There is a risk that if standards are not updated, any new school building program will lock in outdated requirements. It is also well recognized in the construction sector that there is a substantial challenge with compliance with large numbers of buildings across all sectors not performing to design standards. And addressing this requires both data on performance and better enforcement of regulations to ensure that building standards are met. So your recommendation, if I've understood this correctly, is that higher standards for ventilation should be in place for schools. Is that right?
Yes.
Standards are too low at the moment.
Yes, I mean, if you are in any other building, the Chartered Institute Building Services Engineers recommend 10 litres per second per person
I see.
ventilation. The HSE recommend between 5 to 8 litres per second per person as a minimum. If you have a building at the moment, a school building that complies with BB 101, it is probably at the bottom end of that HSE recommendation, if not slightly below it. So our standards actually set out ventilation conditions that are not as good as every other building. And that's even if they're complied with. I mean, the compliance is an issue, not just with schools, it's across everything. Mm-hmm. So, yeah, I would recommend that we had better standards.
Yes. And am I also right that these standards apply to new buildings or major retrofits? So schools that
Yes.
were built 100 years ago don't need to comply with even that lower standard?
No, and that's very normal. So that's true across all buildings, that if the standard updates, you don't have to retrospectively go back and update your building. Mm-hmm. But I do think, you know, for schools and indeed many other public buildings, including things like hospitals, we should have a mechanism for improving those environments, recognising new evidence and recognising the importance of improvements, because otherwise, say you build something once and it's there for 50 years, regardless of the evidence base.
I see. Thank you very much, Professor Noakes. That completes my questions for you.
Thank you. Ms Douglas. She's that way.
Thank you, Professor Noakes. I appear on behalf of clinically vulnerable families who represent clinically vulnerable children and also children in clinically vulnerable families who are at risk of greater risk of severe outcomes from COVID-19. I have three topics to ask you about, Professor Noakes. The first is in relation to the ventilation standards, actually, which we've just touched upon. Your paper from SAGE, EMG and SPIB in 2021, which you've summarised in your statement, made some recommendations about readings for CO2 monitors. It recommended that readings of 800 ppm or below indicated good ventilation, and that values consistently 1500 ppm or higher suggested poor ventilation, requiring mitigating actions. And this was then mirrored in the Department for Education guidance, which we've also touched upon, that was provided. And that said that readings under 800 implied that a space is particularly well ventilated, but that action should be taken to improve ventilation where the readings are consistently higher than 1500, although it noted there's no need to stop using the room. Can I ask you about readings in between 800 and 1500? And would it be fair to say that the SAGE paper leaves a grey area there for readings in between those levels and the actions that might be required if readings fall between those levels?
So I cannot recall exactly what was written in the SAGE paper about the in-between readings, but my understanding is it is a range which, you know, if it's going up, and you've got a measure that shows it's going up, it would be a good idea to perhaps take some action. If it's coming down, then maybe it's going in the right direction already. I think it's also fair to say that we should be really careful about using absolutes with CO2 readings. They are an indicator. So if something's at 850, that doesn't necessarily mean it's poor. That means, you know, if it's 850 and it's going up, that's not a good sign. But there are variations. In a room like this, depending on how the ventilation's set up, you could easily have a difference of 200 to 300 parts per million from where you're standing to where I'm sitting. Which measure do you take? So we have to be really careful that we don't fixate on absolutes. They're indicators. You may get sharp spikes occasionally. You may get high peaks. A high peak does not necessarily mean it's a poorly ventilated space. What you're looking for is consistently high readings as an indicator of poor ventilation.
Okay, and appreciating then that there could be those sort of variations even across a room of 200 to 300. Would it be fair to say that a gap of 700 between 800 and 1500 is quite a bit more substantial? And if that isn't sort of clearly explained to schools, that might leave some room for doubt?
I guess it could be. I mean, perhaps it's marked as amber on a device, and that amber reading would, I think explaining to people, when to keep an eye on things and when to, when to be mindful that things might be going in the wrong direction or the right direction is appropriate to do.
Thank you. Just continuing on that, you've identified earlier that there are several factors specific to school environments which increase the risk of infection, and you mentioned earlier the groups of children that are spending a long time together, the density of classrooms, and the types of activities in schools such as singing and indoor sports. And you've also said just now that ventilation standards should be higher for schools than for other buildings. And you've also said that the guidance on CO2 monitors could have been a little bit more user-friendly, a bit more engaging. Drawing those strands together and appreciating what you say that 850 might not necessarily mean poor, would it be both sort of simpler and safer for the aim to give schools to achieve consistently good air quality, so 800 or less?
I think the challenge there is, in an ideal world, to say, yes, aim for 800 or less. But if you're running a school and your classrooms are all showing higher than that, and you don't have the means to reduce it, you're in a very difficult position. So I think, and again, it's not a case of if it's 800, things are safe. Lower CO2 concentrations typically show better ventilation. It might just show you've got lower occupancy, though, in that room. So there is a little bit more complexity into just saying, here's a number, go below that number and be done with it. Because if people don't have the ability to do something about that, it becomes meaningless, And if you are consistently showing that you're way above that, then you will, and you can't do anything about it, you will probably give up. But I think it's still better if a classroom has a CO2 monitor and they can take a measure which gets it from 1,800 parts per million down to just over 1,000, that's considerably better than, it already being just over 1,000 and trying to get it below 800. But if they can't get it below that threshold and they give up, they'll be back at 1,800 and they'll stick there. So I think it's all about being proportionate and using it to improve things as best as possible. You could also add air cleaners in. If you add an air cleaner in, it won't change your CO2 reading.
Would you perhaps agree then, Professor Noakes, that you could have that as an overarching aim, coupled with perhaps more detailed guidance as to what could be done within that range above?
I think you could. Again, bearing in mind that I work in this area and I'm very familiar with the guidance. You've probably spent a long time looking at this and are probably very familiar with it. You've got to get that knowledge across to thousands of classroom teachers and staff who are already busy. So thinking about how you keep things as simple as possible and as straightforward as possible for people to make positive changes, accepting that with the current resources they have and the current limitations, they might not get perfect.
I'm going to move on, Professor Noakes, because I feel I've spent a little too long on that one.
You've actually gone further than
Have
questions
I?
allowed. Mr. Jacobs referred to stretching my patience. Ms. Douglas, you must stick to the questions that are allowed, all right?
I will, my lady. Thank you. The next topic is the Class Act study. And Professor Noakes, you mentioned, you described the findings, particularly on the impact of air filters on illness absences. And you said that you were confident in those findings that illness absence was lower in primary schools with HEPA air filters. You've also said that studies around environmental interventions are not like a clinical trial. And we've heard earlier that clinical trials are referred to as a gold standard. Can I ask you, is it fair to compare those two methods?
Could you just explain that? What do you mean by compare those
The
methods?
fact that randomised controlled trials are not possible for environmental measures doesn't prevent you from reaching views of high confidence.
No, that's true. So I and it means when we do intervention trials in schools, we maybe would take some of the elements from a randomised controlled trial, but recognising you can't control everything in quite the same way as you would in a clinical setting.
I'm sorry, Ms. Douglas, where is this question allowed?
My lady, I was picking up on the evidence of Professor Noakes about the
Are
type
you
of-
allowed to ask certain questions that I specify, Ms. Douglas? And I spend some time and very carefully specify.
Apologies, my lady. I was coming on to the question in this topic, which is, which I think has been touched on already, which is that you've mentioned the delays in the publication of this aspect of the study, but it's right, isn't it, that Professor Noakes, that other papers within the Class Act study have been peer reviewed and published. Is there any reason why there would be a delay on this one?
It is entirely down to the journal publication processes. It's very normal in academic publishing that you might send a paper to a journal, a very high-profile journal. They might take quite a long time with it, and then they might not accept the paper. So you sometimes have to try again a second time and a third time. But it's a very normal process, and we have unfortunately been subjected to some very, very long peer review processes, one which almost 18 months with one journal. And that is outside of my control.
Thank you. And then just very, very quickly on my last question, which is just in relation to the provision of air cleaning devices. And I think you mentioned earlier, you were recalling the number that were provided. It was 9,000, which you described as quite a substantial number. But if we contrast that to the numbers of CO2 monitors, 700,000 provided to over 45,000 schools, in your view, was the volume of air cleaning devices provided sufficient?
So I think in terms of, it's very hard to put a number on it. With a CO2 monitor, it's straightforward to say every school or even every classroom perhaps would benefit from one. With an air cleaning device, that's not necessarily the case. And there are no silver bullets in this at all. I think what's most important is that schools use knowledge to do the right risk assessments, identify where there might be poorly ventilated environments, identify where they might have children who are particularly vulnerable, and use that to inform where to position, where there might need to be interventions. And in some cases, that might be an air cleaning device. In other cases, it might be a retrofit of ventilation. In other cases, it might simply be just using what they've currently got better. So it's very hard to say, is this number correct? Because it's not the case that every environment needs an air cleaning device.
Thank you, Professor Noakes.
Thank you,
my
Ms.
lady.
Douglas. That completes the questions we have for you, Professor. I understand not only have you been extremely helpful, but you've interrupted your holiday to come along today.
I have indeed.
Well, I mean, we're even more grateful. Thank you very much indeed for going beyond the call of duty, I think. But thank you so much for interrupting your holiday, but for all the help that you've given and for all that you tried to do during the pandemic as well. So thank you again.
Thank you very much.
I shall return at 20 to 2. All rise.